In this module, we'll discuss sutures and suture techniques. Selection of the type of suture material and needle is dependent on tissue type and thickness, the location in the mouth you are suturing, the ease of handling of the material, its cost, and the planned time of suture removal. There is a trend towards the use of smaller suture material and needle diameters. This trend is consistent with the desire to avoid flap trauma and minimize disruption of the remaining blood supply to the flap. Of the materials available, there are many resorbable and non-resorbable choices. Let's explore the resorbable choices first. Surgical gut is a general-purpose suture that may be used in gingiva or mucosa. It is designated as plain, or if it has been treated with chromic salts to prolong its resorption time, is called chromic gut. Both plain and chromic gut have moderate tissue reactivity in that these products resorb through an enzymatic process similar to the digestion of animal proteins. Tensile strength for both materials is poor, with a half-life of 5 to 6 days for plain gut and 14 days for chromic gut. One other material that is commonly used is polygalactin 910, which sells by the trade name of Vicryl. Vicryl is a general-purpose suture with minimal tissue reactivity. It is easy to use, has good tensile strength, and a half-life of 2 to 3 weeks. For non-resorbable materials, we have many choices. Surgical silk is a general-purpose suture that is used only in keratinized tissue. It has high tissue reactivity since it is a braided material, which can wick bacteria into the wound. It is easy to use and has a fair tensile strength. Polytetrafluoroethylene, or PTFE sutures, are another option. They have the advantage of having minimal tissue reactivity, but can be challenging to work with on an initial knot tie. They have good tensile strength, and because of their minimal tissue reactivity, can be left in place for many weeks. The ideal surgical needle has several properties. It should be made of high-quality stainless steel, be as slim as possible without compromising strength, be stable in the grasp of the needle holder, and be able to carry the suture material through the tissue with minimal trauma. Suture needles are manufactured in round or triangular shapes. Round needles pierce and spread the tissues with minimal cutting. However, they are limited to the use of easily penetrated tissues like abdominal viscera. In dentistry, the needles that we typically use are triangular shaped. There are two types, a cutting or a reverse cutting. In these needles, each of the three edges serves as a cutting edge, and they are used to penetrate through tough tissues. Conventional cutting needles, as you see here on the left, have a cross-section that appears as a triangle. These cutting needles have their cutting edge on the concave surface and are very useful for suturing skin. Reverse cutting needles, as you see here on the right, are an inverted pyramid. Reverse cutting needles have their cutting surface on the convex surface and are ideal for tougher tissues such as oral mucosa or gingiva. Reverse cutting needles have more strength than conventional cutting needles, and there is a reduced risk of cutting through tissue. Therefore, they are preferred for gingival surgery. There are 4 principles that we follow anytime we are suturing a site. These 4 principles are: number 1, use the least number of sutures as necessary to close the wound. This will ensure an adequate blood flow to the flap. 2, take an adequate bite of tissue. This means to not place the suture entry or exit point at the papilla apex, but more closely positioned near the mucogingival junction. If you place your suture near the papilla apex, you will compromise the vasculature and possibly cause the suture to pull through the flap if there is flap edema. Ideally, your entry and exit point should be 2 to 3 millimeters from the flap or papilla margin. 3. You want to have minimal tension on the flap after placement of the suture. If you see blanching of the flap, you have too much tension and must remove the suture and replace it. And 4, we always want to place the suture in keratinized tissue, if possible. This helps ensure the suture stability and also provides the patient with minimal discomfort. There are multiple different suture techniques that you can utilize based upon your surgical objective. Here we will focus on 3: the interrupted, the continuous sling, and the mattress suture. The interrupted suture is the most common type of suture placed. It works well if both the facial and lingual flaps require similar amounts of tension and heights. Interrupted sutures may be used when flaps are replaced. Here in the photos, you can see the actual steps for placement. First, in the left panel, you can see the suture is started on the facial side, where the suture needle is passed through the facial flap, through the interproximal space, picking up the lingual flap from the underside, and then exiting on the lingual surface. Next, in the right panel, you can see the suture is then placed around and then threaded through the interproximal contact and then ultimately tied on the facial side. This is the interrupted suture technique. Sling sutures allow positioning of the facial or lingual flap independent of the opposing flap. For example, the sling suture can provide coronal positioning of the facial flap, while the lingual flap can be placed in an apical position. Continuous or double continuous sling sutures are used when an entire sextant or quadrant is being sutured. This panel demonstrates the double continuous sling, which is useful in posterior crown lengthening procedures. I will post in the files section of Canvas instructions on how to perform this suturing technique, because it is complicated as you're making your turn, as you can see here in panel D at the posterior segment. The external mattress sutures is useful in areas where it is advantageous to keep the bulk of the suture material outside the flap. If interproximal intrabony defects are treated with bone grafts, the external mattress eliminates or minimizes the amount of suture in contact with the graft material. In addition, mattress sutures can better control positioning of the papilla without creating additional tension on the papilla tip. Vertical mattress sutures are better suited for narrow interdental areas, whereas horizontal mattress sutures work well in broader interdental areas. The horizontal mattress suture is the technique you will commonly utilize when you perform site preservation, as it maintains not only stability of the flaps, but stability of the membrane that is placed as well. Internal mattress sutures are used when it is desirable to have the papilla position in a more upright position in the embrasure space. These are typically used in an anterior region when aesthetics are highly desired. Horizontal mattress sutures are used in wider embrasure areas to give better control of the papilla tip, and can be used in an anterior area to avoid compressing the papilla, as you see here in this panel. To perform this technique, you start on your facial side. The suture penetrates the facial flap, is threaded underneath the facial flap, and then exits out the facial flap. Next, the suture is placed under the interproximal contact, where this same procedure is repeated on the lingual aspect, where you penetrate the lingual flap, proceed underneath the lingual flap, and then exit on the opposite side. Next, the suture is then threaded back through the interproximal space and tied on the facial. Here you can see a crisscross configuration is done. This is very useful in maintaining accurate positioning of a membrane that would be placed in a site preservation technique. It doesn't always have to be done this way, however, and you can leave these segments horizontally if you have an edentulous space. Last, I would like to discuss the use of periodontal dressings. Periodontal dressings can be considered for use to enhance flap stability and protect the surgical area. There are two types that we typically use, Copac and Barricade. Most periodontal dressings currently in use are eugenol-free and are either a two-paste chemical cure material containing zinc oxide, mineral oils, rosin, and a bacteriostatic agent, or a fungicidal agent. In this upper right panel, you can see that Copac is supplied as a base and a catalyst. Today, these are supplied in an auto mix gun type configuration, which makes mixing and application very easy. In the bottom right panel, you can see the Barricade after it has been placed in the area of surgery. The other material we have is a visible light cured gel that's composed of polyether urethane dimethyl methacrylate resin in a silonated silica, and it's called Barricade. Barricade is a nice material to work with because, as you can see, it can be a very clear material so that you can assure your positioning of your tissue. Both types of these dressings rely on a mechanical lock into the embrasure space for retention. When the embrasure spacers are filled with gingiva, these dressings have a tendency to loosen and displace rather easily. If wound stability is a rationale for your dressing placement, their use in these instances may be counterproductive. Barricade is somewhat more adhesive to the surface of the teeth if applied to dry surfaces. Both of these dressings require a mechanical lock to remain non-mobile during the first 7 to 10 days of healing. Again, the advantage of Barricade is its translucent gingival coloring, making it more suitable for use within aesthetic areas. This concludes our discussion on sutures and suture techniques.